A very good afternoon to one and all. I'm Dr. Sidra Ansari, and in this session, I'm going to talk about cleft lip and palate and its management. By definition, cleft is nothing but a crack, a fissure, or a split, or a gap in the region. Okay, orofacial cleft is nothing but a congenital deformity that arises because of the changes or disturbances that take place in the embryological level in the orofacial region. The zone affected by the common orofacial cleft are: you have the lip that is affected, the alveolus, the hard palate, the soft palate, the nose to some extent, and eye in very rare orofacial clefts. Etiology of orofacial cleft. It could either be hereditary or environmental causes. Now, hereditary is mainly because of the link, that is male recessive sex-linked genes transmitted can cause hereditary changes. Then at the same time, like any other congenital abnormalities, it has some of the environmental influence that affect during the first trimester of pregnancy. That is, any viral infection, long-term drug use like antibiotics, steroids, then diabetic drugs that are used, anti-epileptic drugs that are used, patient on alcohol consumption, smoking, consanguineous marriages within close relatives like cousins can also cause developmental deformities. And at the same time, maternal age also play a very important role. What I mean to say by maternal age is the older the mother, the chances of getting a defective zygote is more and resulting in formation of craniofacial anomalies. Let's move on to the embryological aspect of cleft lip. Now, before we move on to the embryological aspect of the cleft, we should know the embryology of the normal face. Okay, the mid portion of the face developed anteriorly and inferiorly in front of the foregrain. Now, it starts to develop with the formation of frontonasal process. Then, on either side of these frontonasal process, ectodermal thickening take place, resulting in formation of nasal plecodes. Now, these nasal plecodes get eventually invaginated by mesoderm and result in a horseshoe shape formation. Now, this horseshoe shape formation results in formation of two limbs, that is the medial limb and the lateral limb. Now, and resulting in formation of medial nasal process and lateral nasal process. The medial nasal process fuses with the frontonasal process to form the upper lip, the premaxilla, the philtrum. Whereas the lateral nasal process form the alar cartilage or the alar portion of the nose. Now, as below this stomodium, there is mandibular arch that tries to develop. The mandibular arch is basically below the stomodium and the mandibular groove. Okay, it forms the caudal limit of the face. Now, mandibular arch grows from both the side and come in the middle, and they join. They join at around 4 to 6 weeks of gestation. Okay, as they joined, they constitute the formation of the lower lip, the mandible. Now, above the mandibular process, there is a maxillary process. Now, maxillary process fuses with the globular process to form the upper lip, the maxilla, the zygoma. Then there are lateral projection of the maxillary process which forms the palate. Now, initially, the palatal shelf, which form the secondary palate, correct you, because the primary palate or premaxilla is formed by the frontonasal and the medial nasal process. Then these lateral projections that arises from the maxillary process, they are basically oriented in a horizontal, downward, oblique fashion initially because the tongue is raised. Now, as the child or embryo developed, the mandible will move forward, and along with the mandible, the tongue move forward. Now, this takes place at the around 7th week of gestation. As the tongue move forward, these palatal shelf, they move more horizontal position and eventually fuse with each other and form the secondary palate. Now, the secondary palate anteriorly fuses with the primary palate at the incisive foramen, and the septum of the nose eventually join the anterior part of the palate. Now, this is how the entire embryology takes place. Now, what happened in cleft? Now, in cleft, the fusion of these processes are hampered either because of epithelial or you can say mesodermal ingrowth in that area. So, the cleft is because of difficulty or non-fusion of the medial nasal process with the frontal nasal process, or there is non-fusion between the lateral nasal process with the medial nasal process, or with the middle nasal process and the maxillary process. They do not fuse in their proper fashion, resulting in formation of cleft. And as far as isolated cleft of hard palate is concerned, as I mentioned, in cases wherein the mandible doesn't grow, the tongues try to remain in a high position, because of which the palatal shelf cannot come to a more horizontal position and fuse. So now these conditions are wherein the mandible is retrognathic, or if you have a Pierre-Romberg syndrome, wherein the mandible doesn't grow at all. The tongue tries to move upwards superiorly and posteriorly, so the palatal shelf will not fuse, resulting in formation of isolated cleft of the palate. Now let's move on to the classification of cleft lip and palate. Now View has given a very simple classification depending upon the anatomical position. Group 1 is cleft of the soft palate alone. Group 2 is a cleft of the hard and soft palate. Group 3 is complete unilateral cleft extending from the uvula to the incisive foramen and then deviating to one side through the alveolus. And group 4 is complete bilateral alveolar cleft. Now Kernahan has given a Y type of classification by trying to explain different variation that can occur in case of cleft. Sometimes you might have an incomplete cleft lip, sometimes you might have a complete cleft lip and alveolus only without a palate, or in some cases you will have a complete cleft lip and palate, or just there is split of the palate and uvula. So Kernahan has made an attempt to simplify these variation by giving a Y-shaped classification. What he has done is that he had divided Y into different number zones which will correspond to specific anatomical region and number it from 1 to 9. Okay, 1, there is cleft, incomplete cleft of the lip on the right side. 2 is complete cleft of the lip. 3 is cleft lip and alveolus, that is the premaxilla is clefted. 4 is the incomplete cleft of the left side. 5 is complete cleft lip. 6 is complete cleft lip and alveolus, that is the premaxilla. 7 is cleft of the hard palate. 8 is cleft of the soft palate, and 9 is cleft of the uvula. Now 7, 8 and 9 are behind the incisive foramen, that is on the hard palate region. In this way he has tried to classify different variation, permutation and combination of cleft that can occur. Now let's move on to the associated deformities with cleft. Now cleft always have a facial deformity. It affects the profile of the patient, it affects the oral sphincter, it affects the knees, it affects the nose. Now because of the cleft, the orbicularis oris does not form an oral sphincter. Rather than that, it has an abnormal attachment. The orbicularis oris on the non-cleft side get attached to the anterior nasal spine. Now as it gets attached to the anterior nasal spine, it tries to pull the anterior nasal spine towards the non-cleft side. That is, the midline is shifted. Now along with the anterior nasal spine, the nasal septum will move, so even the nasal septum is shifted. Now because of this shift, the nasal symmetry is affected. The dome is depressed. On the cleft side, the muscle is attached, orbicularis oris muscle is attached to the nasal base rather than attaching to the opposite side. So there is flaring of the alar base. There is depression of the nasal dome and contour is affected. The wider the cleft, the more is the abnormality seen. Now second problem arises feeding problem. Now because this orbicularis oris sphincter does not work, the patient is not able to create a negative suction pressure. So the child is not able to drink or suck the milk out. Because of this, a lot of feeding problem occurs. Secondly, there is a through and through communication with the oral cavity and the nose. So whatever the child tries to drink is regurgitated out into the nose, because of which the child is most of the time hungry and keeps on crying, and the parents doesn't know what to do because they're trying to feed but the baby is not able to drink. Now what you should explain the parents in this case is that rather than keeping the baby at 90 degree, you keep the baby at 40 degree angles and try to feed. Rather than using conventional bottles, use those bottles which has a wider hole at the nipple so that the baby doesn't have to exert too much to suck the milk. So it should have a wider hole at the tip. Or you should use a modified bottle wherein the nipple is longer so that it directly goes into the oropharynx, because of which the regurgitation is less. And after every feed, frequently try to bob the child. So this way you should keep in mind to avoid any kind of feeding problem. Then the third problem associated with speech, with the cleft, is the speech problem. Okay. Now, because of the cleft, a certain consonant like P, T, D, K, T, patient is not able to speak properly. Secondly, there is increased hypernasality. Even though you do a surgery, the hypernasality is always there. They will never have a normal speech like us. There is always articulative defect. Now, what I mean by articulative defect, now these occur when the teeth are not in proper position, when the alveolus is not proper. At that time, articulated defect occur. Now, this occur because pronouncing certain word, we touch the tongue to the teeth as well as the alveolus. So because of these defect, articulative defects are present. So in these cases, speech therapy is a must. A continuous speech therapy is very important. Like surgery is 50% and speech therapy is 50% to improve the overall status of the child. Then the fourth problem associated with cleft is dental problem. Yes, as I mentioned, if there is a complete cleft, the alveolus is also cleft. So the tooth is not able to erupt in its normal position and will erupt in anywhere the tooth finds the place. So there is malocclusion, there is crowding, there is missing teeth, unerupted, impacted teeth are seen in these cases. So an orthodontic treatment becomes must in cleft cases. So after the age of 12 to 14 years, ortho treatment becomes very important. Then the last problem associated with cleft is residual deformity. Whenever you treat a cleft patient, you will not do anything good in just one surgery. It requires a multiple surgical approach. But after doing these surgeries, some amount of residual defect will always occur. Like after there is nasal deformities present, you will try to correct the nose, but you will never get 100% symmetry. Some here and there residual defect will always going to be there. You have to inform the patient about this and take a proper consent. Let's move on to the aims and objectives of the management of cleft lip and palate. The aims and objective is to increase the survival rate, because developing country like India, most of these problems are hit towards the lower socio-economic status people, wherein the nutrition level of these people are less. At the same time, the baby is not able to take the nutrition properly, because of which the survival chances are less. There's a lot of abortion that is happening out. That's the reason why we need to treat these cases, inform the patient that these are treatable cases, and we should increase the survival rate. Improve the overall function of the patient, improve the aesthetic of the patient, and better social acceptance and social integration. Now, the general protocol that is used for the treatment of cleft lip and palate is patient counseling and feeding advice is a must. It should start from the first appointment and it should continue every time the parent comes to you. Because for the parent, this is the first time. They don't know how to handle it. They are scared that this is a taboo. You need to explain them that this condition is not a taboo. It's a treatable condition and the patient can live a normal life like you and me. You need to counsel the patient. You need to counsel the patient regarding the feeding habits, regarding how to feed the baby. After the feeding habit, you need to inform the patient regarding the number of surgeries that is required. In treating a cleft patient, one surgery is not sufficient. You have to do multiple surgery in a planned fashion. For that, the patient parent should be mentally ready for the child to undergo surgery. Because this surgery does not take place at the age of 20 years. The surgery start as early as 5 months, when the baby is 5 months. So you need to make the parents aware of the surgical timings and the number of surgeries that are required, wherein counseling plays a very important role. Then come the surgical repair of the lip at the age of around 5 months. After the lip, we address the palate at the age of around 12 to 16 months. Then you do language assessment at 18 months and speech assessment at 3 years of age. If required, you do a pharyngoplasty or soft tissue redo palate procedure to enhance the speech and decrease the hypernasality at the 4 years of age. Alveolar bone grafting is done after the age of 6 years. Orthodontics is done after the age of 12 years or 10 years. And secondary surgical procedures like rhinoplasty is done after 16 years. Or if these patients have hypoplastic maxilla, okay, because of the multiple surgery and scarring, so you do a mid-face advancement. Most of the time you do with the extraoral rigid distractor. So if you're planning for a mid-face distraction, you do the distraction first, then you do the rhinoplasty surgery. Let's move on to the management of cleft lip. The management of cleft lip, there is always a debate regarding the timing of the treatment, whether it should be done early or late. Some of them think that as early as around 5 to 7 days is important. Some of them think that we should wait for around 5 months. But frankly speaking, in our Indian scenario, where we do not have advanced neonatal post-operative care, we should wait for some time so that the patient can accept the anesthetic procedure and can accept the post-operative protocol. So like around 5 months is acceptable in our scenario. Now before you go for the surgery, pre-operative evaluation is very, very important. Now upper respiratory tract infection. Now kids, small babies or months babies are very prone to upper respiratory tract infection. Any change in the weather can result in cough and cold. And these patients with cough and cold post-operatively will have wheeze and stridor. Wheeze and stridors are nothing but manifestation of difficulty in breathing. And we all know that these tiny babies have very tiny lung capacity and small trachea. Any little amount of difficulty in breathing can directly affect their saturation level, and the saturation level will fall suddenly and you not even know that. So you need to take care that the upper respiratory tract infection is under control. Secondly, check for any ear infection. This is very important when you're treating the palate, because palate has a communication through the ear. Your nose, ear and your mouth have a communication. So any kind of middle ear infection can infect the palate, and the palate can open up, resulting in fistula formation. Also, check for the nutrition. It's very important. Explain the patient regarding the feeding habits and frequency of feeding, because most of the time these babies are malnourished. So for any success rate of the surgery, the nutrition plays a very important role. Check for the anemic condition of the patient. Check for any other congenital abnormalities like patent ductus arteriosus. Normally it closes after some time, but in cases if it doesn't close, you need to give to a pediatric cardiac surgeon a reference. Check for the milestone. Most of the time the milestones are delayed. At the same time, check for the mental state of the child. Check whether the milestone and the mental stage are matching. Check for that also. Because these patients not necessarily will come to you at an early age. Will come to you at an advanced age, at the age of 5 years, 7 years. And when you are treating these patients, the patient will not cooperate with you. The compliance is not good. So you have to depend on the parents for the compliance. So also check for the mental status of the child. Parent counseling is an extremely important, and its role should never be underestimated. As I mentioned, you need to counsel the parents regarding the number of surgical treatment that is required. Not a one single surgery can make a dramatical change. A multiple surgeries required to treat these patients. Let's move on to the surgical procedure of unilateral complete cleft lip. Now, in this, a number of surgical techniques have been given by different authors. Okay, but the most common and the gold standard technique is Millard incision, because other incision are always a modification of this Millard incision. Okay, as you can see in the first diagram, the marking. The point 1 is the deepest point of the cupid's bow. Point 2 is the highest point of the cupid bow on the non-cleft side. Point 3 is the highest point of the cupid bow on the cleft side, and point 4 is nothing but a back cut at a 45-degree angle towards the base of the columella. After this, you make a straight line from point 3 to the junction between the dry and wet vermilia. All the green area that I have been striked out, these are sterile zone. That is, these zones are actually not present in normal, but in cleft they are present because epithelial have grown. So you need to remove this sterile zone. On the cleft side, your marking is 4' at the base of the columella and 3' at the highest point of the cupid's bow. Again, here you will make a perpendicular marking just below 3' point at the dry and wet vermilion border. You will remove the sterile zone and you will give a cut from 3 to 4 in such a way that you raise a C-shaped flap, as you can see in figure 2. Okay, at the same time you will give a cut at the base of the ala on the cleft side. Now this C-shaped flap will go into the base of the ala on the cleft side and configure the nostril sill area. And then you will undermine the muscle from the skin as well as the mucosa Do the mucosal layer closure, nasal layer closure, muscle closure, and then finally the skin closure. This is how the scar look in the third picture. There will be a triangular scar at the base of the nose, or you can say at the columella region. Now, this is another surgical technique which is nothing but a combination of Millard and Pfeiffer. Okay, wherein Millard is done on the non-cleft side. As you can see the diagram, a C-shaped back cut is given, but here the back cut is not at the columella, but it is below the columella. And you give a small incision into the nostril. And on the cleft side, you will give a Pfeiffer VVS incision, starting from the highest point of the white roll into an S-shaped fashion into the ala of the nose, inside the nose. Okay, once you do the incision, then you'll do your dissection, remove the sterile area. Minimal muscle dissection is done on both the side. Along with that, you'll do ala nasalis dissection. As you can see in the second photograph, ala nasalis is dissected. Once you have done the muscle dissection, you will give around 5 mm of nick in the vestibular region on the cleft side and do a wide subperiosteal dissection in the piriform area, the alar area, the lateral surface of the nose, the intraorbital and the malar area. Now this wide subperiosteal dissection will move the entire muscle mass towards the midline. We need to mobilize because the muscles are in their abnormal position. We have to move them into a more physiological position. So you'll do a muscle mass elevation to mobilize it. Once you have done on your cleft side, move towards your non-cleft side. Do the dissection, remove the sterile area, do the muscle dissection. Then try to remove all the attachment away from the septum, anterior nasal spine, expose the septum and correct the septum. Because in cleft, the septum is deviated towards the non-cleft side. So you need to move it towards the cleft side, maintaining the symmetry. Once you have done, you will do the suturing of the septum. You will close the nasal layer. Once the nasal layer is closed, you will do the ala nasalis stitch. Now this ala nasalis suture will give you a nasal symmetry and maintain the alar sill. After this, you will do mucosal suturing, muscle suturing and finally the skin suturing, as you can see in the photograph. Let's move on to the surgical procedure for bilateral lip. In this case also, in this figure, there is a combination of two techniques, Millards and Pfeiffer. Millard incision is given in the prolabium area, whereas the Millard is given in the cleft area, whereas Pfeiffer wavy incision is given in the prolabium area. Okay. Once you have done, remove the sterile zone, do the minimal muscle dissection on the cleft side. After doing the minimal muscle dissection, do ala nasalis dissection. Once you have done the ala nasalis dissection, similarly you will do periosteal mass elevation. Once you have done that, you will dissect the prolabium. The prolabium dissection is done to separate the vestibular mucosa from the skin. All the fibrofatty tissue is removed and the vestibular mucosa is trimmed. Okay, after doing this, you will do perialveoloplasty. It is done to prevent the V-shaped junctional fistula that occur in cleft palate. You have done facial mask elevation. From the facial mask elevation, some amount of a mucosa from the alveolar part you will try to reflect on the palatal side. And you will try to suture this with the nasal mucosa. Okay, here the nasal floor is sutured. After suturing the nasal floor, the ala nasalis muscle is sutured to get the proper nasal symmetry and nasal sill. After that, the mucosal suturing is done, as you can see here. Once you have done mucosal suturing on both the sides, you do muscle suturing followed by skin closure. Now, what are the complications of lip surgery? Now, pain and discomfort is obvious for any type of surgery. Some amount of bleeding can take place. Post-operative for around 24 hours and it will stop automatically. Infection and tissue necrosis can take place. Wound adhesions can take place. You should advise the patient that to keep the babies in such a way, not to keep the baby in a cradle and go away. What if the baby falls in front of the face? Like it will injure the lip area, result in wound adhesions. Sometimes, no matter you try your best, white roll mismatch can occur. There could be tenting of the cupid's bow. There could be flaring of the ala base if the ala nasalis stitch is not done properly. And there will sometimes you have over tightened the stitch could result in nasal stenosis. Let's move on to the cleft palate. Okay. Now, In this slide, you will see the difference between the normal anatomy of the palate and the anatomy of the cleft palate. In the normal anatomy of the palate, the levator muscle is in a horizontal fashion, whereas the tensor muscles are vertical, moves along the hamulus, and their tendon are horizontal. So basically their orientation is in the horizontal direction. Okay, whereas in case of the cleft, all these muscles, rather than joining towards each other, forming an horizontal sphincter, they get attached to the posterior border of the cleft. They are attached vertically. So our main aim of treating a cleft patient is to close the fistula, that is to close the gap by the mucosal layer, and to bring the muscle in proper position, that is in a more horizontal position. Now, this slide shows different type of cleft palate, that is incomplete cleft palate. Second picture show a complete unilateral cleft lip and palate, and the third picture will show a complete bilateral cleft lip and palate. Now these are surgical steps that are seen in case when you're treating a cleft palate. Okay, the most common technique that is used to treat a cleft palate is the Bardach two-flap technique. Now this two-flap technique, you will raise a finger-shaped mucosal, complete mucoperiosteal flap, which is based on greater palatine artery. And after raising a complete mucoperiosteal flap, you will do nasal dissection. Okay, you will try to close the cleft in 3 layers: the nasal layer, the muscle layer, and then the oral layer. Once you have done the nasal dissection, you will try to close the nasal layer. After that, you will do muscle dissection. The muscles that are positioned anteriorly towards the hard palate, you will try to move them down inferiorly in a more horizontal position, and then you will do the oral layer closure. Now, once you have done the oral layer closure, some of them put a gauze pack to prevent hematoma and bleeding, like a pressure pack. Or some of the time, you're trying to push the oral layer into the center. So some gap occur on the lateral aspect. Sometimes people add Ab-gel to this gap to prevent bleeding or to prevent dead space. Or sometimes they also use buccal pad of fat to close this gap, depending upon surgeon's preference. This slide shows the closure of the bilateral palate. Now, complication that can arise in case of palate. As I mentioned, pain and discomfort is always going to be there. Some amount of bleeding does take place. Palate bleeds, so some amount of bleeding is acceptable. Infection and tissue necrosis. As I mentioned earlier, if the patient is having any middle ear infection, there are chances that the palate might get infected. Secondly, it is in the oral cavity. Patient is going to drink and eat. If the mouth oral hygiene is not maintained, food will get impacted into the stitches and infection can occur and wound dehiscence can occur and fistula will develop. That's the reason why post-operatively you need to ask the patient to have liquid diet after palate surgery. Now these liquid diet will prevent any kind of, if you ask for semi-solid or solid diet, it will get stick. To avoid that, ask liquid diet so that it doesn't stick, and have lot of irrigation and mouthwash or clean the mouth, drink a lot of water after that. Okay, let's move on to the post-operative care of cleft lip and palate. In case of cleft lip, the pressure dressing is maintained in unilateral cleft lip for 5 days and for bilateral for 10 days, just to prevent any kind of injury and provide approximation in the initial healing phase. The feeding instruction is going to be the same. What you used to feed before the surgery, the same thing you have to do after the surgery. There is no change in the feeding habits or pattern or direction. A course of antibiotic is given. Okay, monitor the patient. The patient should not fall while sleeping. Take care of that so that there is no direct injury to the lip. While in case of palate, the post-operative care includes check for any kind of bleeding. If it is bleeding profusely after 48 hours, then you need to come back. We need to see again where is the bleeder, cauterize it if possible, and put a pressure dressing. As I mentioned, some people put a gauze pack into the oral cavity as a pressure dressing. They suture it to the palate. Okay, so this has to be removed after 5 to 7 days, because if it is retained inside, it will cause again food lodgement, food debris, and then there is infection. And 1 month compulsory liquid diet for cleft palate patient. Everything but liquid. After 1 month, you can eventually start with semi-solid and then solid diet. The parent should see to that the patient does not keep anything in the mouth like a pen or any kind of, the kids have a habit of whatever they see, they try to put inside the mouth. When you have done a palate surgery, try to avoid anything in the mouth that it will cause any kind of mechanical trauma. Alright, and whenever regular follow-up is very important. Thus, with this, I would like to conclude by saying that the choice of the technique for primary surgery of cleft lip and palate should be based upon the philosophy that produces the best function and aesthetic outcome. Okay, certain preoperative anatomical feature may lead the surgeon to choose one particular procedure. No matter what is the surgical procedure, but what suits the surgeon best should be done. Keeping in mind that cleft lip is a defect in a three-dimensional problem. That is, it is not just the lip, it is the lip, the nose and the alveolus, and we need to address all of these as a whole. Thank you.